Good evening. I'm Belinda Paulson, Vice President of Helpline Education and Outreach at the Cancer Support Community. Welcome to our live webinar today. For those of you joining us for the first time, let me tell you a little bit about Cancer Support Community. For more than 40 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of this disruptive disease and get back to their normal lives. Whether accessing our free services in person at one of our 200 locations, online, or via our toll-free helpline, you are getting a team of licensed professionals, community navigators, and resource specialists providing patient navigation, financial counseling, genetic, biomarker counseling, clinical trial, pediatric support, and more. Today, we are going to discuss metastatic non-small cell lung cancer to better understand this unique experience, treatment options, and challenges that may arise when diagnosed. We are excited to host today's event in partnership with Lung Cancer Research Foundation. We are grateful for the generous support of NovaCure, who made this program possible. I'm extremely grateful to have with us today Dr. Hussein Borgai and Pamela Dyke. Dr. Borgai earned his degree at the Philadelphia College of Osteopathic Medicine and completed a residency at Graduate Hospital in Philadelphia. Since completing his fellowship training at Fox Chase, he has been involved in a number of clinical trials aimed at developing new antibody-based therapies and immunotherapies for patients with lung cancer. In addition to this, his clinical practice and participation in immunotherapy-based clinical trials, Dr. Borgai is the principal investigator of a laboratory that develops new monoclonal antibodies and novel immune modulating drugs with the aim of bringing these approaches to clinic. We're so happy, Dr. Borgai, to have you. And at this time, I give you an opportunity to share anything else you'd like to share, any disclosures, to the audience.
Well, thank you so much for the invitation. I'm really appreciating the opportunity to be here with you and to have this discussion with everyone. As you mentioned, I do like to start by mentioning that I am an advisor and a consultant to many of the pharmaceutical companies that have drugs in area of lung cancer treatment, both in the metastatic setting and in the early stage disease. These include oral agents, targeted drugs, immunotherapy, and chemotherapies. Again, thank you for the invitation.
Thank you for being here. And then our next guest is Pamela Dyke. Pamela has been married for 32 years and has children and 6 grandbabies. In 2018, she was diagnosed with stage 3 non-small cell lung cancer. Pamela will share a little bit about her experience with cancer, but I wanted to also share that Pamela is an advocate that started her support group and actively advocates whenever she can. Her goal is to help others and encourage them to never give up. Pamela, thank you for being here tonight. And would you like to share anything with us?
You said it. You said everything. So,
Okay. Okay, great. Well,
thank you for having me.
It's wonderful. Thank you for being here. So we're here to really understand the metastatic non-small cell cancer. So Dr. Borgai, can you please start off by explaining to us what non-small cell lung cancer is and what it means to have metastatic diagnosis?
Sure. So lung cancer comes in a variety of subtypes, or what we in our medical jargon call histologies. The most important distinction is between small cell and non-small cell. majority of the lung cancers diagnosed in the US are of the non-small cell variety. Non-small cell comes with, again, multiple different subtypes, or again, what we call histologies. The most common one is something we call an adenocarcinoma. The second more common one is squamous cell carcinoma. And then the third more common is sort of a large cell type of histology, and there are smaller subtypes beyond that. But the two main categories of lung cancer, adenocarcinoma and squamous cell carcinoma, they originate from different cell types within the lung. So as you all know, malignancies, cancers develop as a result of something that goes wrong with our own cells, the cells that we all have in our bodies. And there are different theories as to why this might happen, but damage of some sort or a genetic alteration of some sort in different parts of the lung can lead to different histologies and different lung cancer formation. So the diagnosis and the histologies all have to do with the cell of origin. Once a cancer is diagnosed, and this is true for many cancers, including lung cancer, what sort of determines the treatment options is what we call the stage of the disease. And the staging criteria, for the most part, goes from stage 1, which is early stage, to stage 4, where in this case, lung cancer has basically traveled outside the immediate lung area to perhaps opposite lung, lymph nodes in the abdomen, other parts of the body. So the disease is no longer contained in one area, and that qualifies for what we call metastatic disease. In lung cancer, there are several organs where the cancer cells prefer to go to. And technically, it can go anywhere, but lung cancer in general, once it leaves the lung, prefers to go to the brain, the bone, and the liver, and there are two glands on top of each kidney. They're called the adrenal glands. These are the more common sites where we find evidence of metastatic disease. And again, that would be stage 4 disease. Lymph nodes are commonly also involved. That can happen early on in the course of the treatment. But sort of in a nutshell, that's what we mean by lung cancer, and that's what metastatic disease or stage 4 disease means.
Mm-hmm, mm-hmm. Okay. And can you tell us, like, typically who would receive the diagnosis?
Now, this has changed over the past 20 some odd years that I've been doing lung cancer. At this point, I would say anybody with lungs can get lung cancer. It's very difficult to sort of paint a picture of somebody that we would call a typical lung. There's no such thing. In
Right.
the old days, we used to think that, for example, smoking can contribute to it, and that has led to this stigma that's associated with lung cancer, which is totally unfair and uncalled for. Right now, worldwide, I would say, again, mostly US and Western Europe, anywhere from 20 to 25% in some literature, maybe even 30% of patients who get lung cancer can actually be never smokers, patients who were never exposed to cigarette. They didn't live with a smoker, so they have no secondhand exposure. And quite frankly, we don't understand why so many of our patients are under that category of never smokers. These tend to be, unfortunately, very young patients who are diagnosed. So at this point, I would say, if you have lungs, unfortunately, you can get lung cancer, and that's the assumption that we have. So a lot of our studies are trying to concentrate on figuring out why this is happening. As I said, we see this phenomena worldwide. In some parts of the world, mostly in Asia, this is an even larger issue, a bigger problem in terms of never smokers having lung cancer. So quick answer is, you have lungs, you can get lung cancer.
Cancer. Thank you. Thank you. And Pamela, can you tell us about your experience with non-small cell lung cancer?
Yes, ma'am. I was diagnosed in 2018 and my lower back was hurting, so it wouldn't stop. So my husband took me to the hospital and we did a CT, and that's when they found a little spot in my upper right lobe. and it was in my lymph node, in one of my lymph nodes.
Okay.
So that's when I did get a second opinion. I did go for a second opinion. And then I came back to my hometown and did immunotherapy. And in 4 treatments, it was gone. So 7 years later, a little spot showed up again. And I just had the SBRT done and 5 treatments of it, and it took it.
Thank you. Thank you. Dr. Burgai, what are the treatment care options for metastatic non-small cell lung cancer?
Yeah, so we use everything available to us for management of non-small cell lung cancer in the metastatic setting. The only caveat is that surgery usually is not offered. Now, that is an evolving field, and there might be additional studies looking into this. But as of now, we use chemotherapy, we use what we call immunotherapy, and we use targeted therapies. As you heard from Pamela, we can also use very focal radiation called stereotactic radiation for management of this disease. Metastatic lung cancer is a disease where the cancer cells are basically floating around. And even though we can only see them in certain areas, most likely the cancer cells are around, and we just don't have the technology to see them right now radiographically. There are blood tests where you can possibly find evidence of cancer cells, but that's a sort of the different discussion. So what we need is a treatment that basically can go anywhere the cancer is. So for that reason, majority of the time, we use drugs like chemotherapy, immunotherapy, or targeted therapy, where the drug is either ingested if it's a targeted therapy with a pill form, or is given IV through IV access if it's chemotherapy and immunotherapy. The drug can go through the bloodstream, go everywhere the cancer is, and try to globally control the disease. Occasionally, as you heard again from Pamela, there are specific clones that might be resistant to whatever treatment we're using, and they might show up. Or there might be disease in a bony site where it's causing pain and discomfort, or unfortunately, sometimes even the brain, because sometimes our treatments are not effective in managing the disease in the brain. And in those instances, we use radiation. Radiation, again, comes in a variety of formats. It can be very pinpoint, stereotactic. If it's in the brain, there's this cyber knife, which is basically a equipment that's used for that. But the idea here is to use very focused, narrow points, beam of radiation to get rid of the specific area where the cancers are growing. And again, we use that to help our patients with metastatic disease. So again, we can get more into the details of what chemo is and what immunotherapy is, or what targeted therapies are. But again, at a high level, those are the strategies that we commonly employ for management of this disease.
And what about clinical trials?
Yeah, very good.
I do like that one.
Yeah, go ahead. You want to make a comment, Pam?
No, I do like the clinical trials because, I'm very interested in them.
Yeah.
And I do research a lot, and I really, I know there's a lot of stuff out there now.
Yeah.
5 or 10 years down the, in the past, there wasn't, but there is now. And I research every day.
Yeah.
Yeah.
I would agree with that. I think the cornerstone of development and progress in all of oncology, in all of cancer, especially for a disease like lung cancer, is clinical trials. We, in fact, have in many of our organizations where treatment algorithms are published and recommendations are published, we start by the statement that for a patient with metastatic lung cancer, the best treatment option is a clinical trial. And it's absolutely right. There are a huge number of clinical trials that are available there. The clinical trials also are using chemotherapy, immunotherapy, targeted therapy, but sometimes these are either novel drugs that are being tested or novel combinations that have not been tested before, and therefore they have to be on a clinical trial. every drug that we use, every single drug that we use as a matter of routine in our everyday clinical practice was an experimental drug and on a clinical trial at some point. That is the only way in this country we can get a drug approved for treatment of metastatic lung cancer and many other diseases. So without participation in clinical trials, we won't have new drugs. Now, obviously, it is extremely brave of patients who agree to go on a clinical trial, because unfortunately, sometimes a trial might not work for our patients. There's no guarantee that any of these drugs are going to work 100% of the time in 100% of our patients. But if we don't learn that, we'll never make progress. So I really appreciate and understand the sacrifice that our patients make by entering various clinical trials. But again, I have to emphasize, without that participation, without having access to novel drugs, we'll never make improvements.
Mm-hmm. Yeah, Pamela, I also thank you, Dr. Burgai. I want to also make sure I give you an opportunity, as I saw your response to clinical trials and from a patient advocate point of view, if there's anything else you'd like to share, please feel.
I agree with Dr. Borgai. Absolutely. If we didn't have the clinical trials, some of them might not work, but some of them do work. I researched so much that, I've read so many people's stories that, that clinical trials have saved their lives.
Mhm.
And so I do believe in them. And I do also believe highly in the biomarker testing too.
Right.
Absolutely.
Yes, and thank you for bringing that up. Can we briefly talk about biomarker testing for lung cancer patients? Dr. Burgai?
Sure, I can take that. So a biomarker is basically a test, a biological assay that can be from blood or it can be from tumor, that would tell us if a particular drug might work better in a tumor that has that particular marker. So that's why it's called a biomarker. In the world of lung cancer, we are actually very fortunate because we have at least 9 biomarker-driven targeted therapies approved for treatment of patients with metastatic non-small cell lung cancer. Majority of these are genetic alterations in the cancer DNA that can be, again, detected through testing the tumor by sequencing it, looking at what the DNA and the RNA of the cancer cell is, or sometimes by having blood drawn and sent for, again, the same level of sequencing, very sophisticated series of tests. We believe that everybody should have access to molecular testing for any stage of lung cancer, but particularly for metastatic disease. We also believe, many of my colleagues who do nothing but lung cancer care, that both tumor and blood should be tested at the time of initial diagnosis to make informed decision about what the appropriate treatment for patient is. These biomarkers are extremely important, and without them, we cannot offer adequate and appropriate treatment for our patients. And again, if one of these biomarkers is available, the difference could be taking a pill at the comfort of your home every day, as opposed to coming to the clinic every 3 weeks for IV administration, which is what now we reserve for patients who do not have one of those actionable, what we call genomic alterations, or those targetable gene alterations. Some of these drugs, even though they're targeted, they can be IV. So not all of them are oral drugs, but there are a couple, and one recently approved, that can actually be administered through an IV. But the advantage of having the biomarker is that it allows us to offer that treatment to patients in whom the drug can be most effective, and therefore avoid having toxicities for a drug that's not going to work in people who do not have the biomarker. So it makes a huge difference. And that's why I think you should always ask your doctor, what biomarker testing have I done? Do I have my tumor? Do I have my blood? Is there anything that's my cancer genome can tell me that would determine what treatment I should get?
Mm-hmm. Thank you. Thank you for sharing that. Pamela, can you share what your overall experience in accessing treatment and the treatment-making process, decision-making process for you was?
Yes, ma'am. Actually, I decided to go with an immunotherapy. I did have a biomarker that was very high, and in 4 treatments, it was gone. But I did continue. My oncologist wanted me to continue the 2-year protocol of it, so I did.
Mhm.
And then, in 7 years, it was gone. Never came back. I had CTs, I had PET scans, everything, MRIs, everything. And then that little spot showed up again after 7 years.
Mhm.
So that's why we did the radiation and beamed it out. I mean, that's just what I say, beam it out, because, I research every day, and if I could help just one person, 5 people, anybody, then I'm going to throw it out there.
Mhm.
I have friends that's passed away with not lung cancer, other cancers, and I didn't get to them. And I needed to get to them. Some of them I did get to, but you know what? They wouldn't listen. So
Mm.
I can't make them do something that, you know what I mean, that they don't want to do.
Mhm.
I had to ask them to go for a second opinion because I do agree with second opinions. And I do agree with third opinions, you know, and that's what I would do. But, other people just want to go with the first doctor they have, and stick with them. And that's not my place to tell them, you know what I mean? But I throw everything I can at them, to try to help.
Mhm. Mhm. So in terms of accessing the treatment that you wanted, your experience has sounds like you were able to get access to what you and your healthcare team decided was best for you.
Yes, ma'am. Yes,
Yeah,
ma'am.
and now you want to raise the awareness and voice of other patients to be
Yes,
active
ma'am.
in their treatment decision. Yes, thank you.
Yes, ma'am. I'll tell you,
Yes.
I don't know how much time I have, but
No, you
I'll
got
tell you,
time. We're
I'll tell
good.
you, 2 years ago, my brother passed away of lung cancer.
Oh.
And I wasn't his medical power of attorney. And me and him was very close, very close. And, it really upsets me talking about it. So I'm just going to make it short. So, his son was his medical power of attorney. His son was never in his life. And he morphined him to death. He killed him. He didn't even give him a chance. He wouldn't biomarker test him. He wouldn't do nothing. So, when it's a family member, it comes close.
Yeah.
And that's just how I feel about it, and just with anybody, a friend, a neighbor, anybody. But when it comes to a family member and you can't do nothing, that's sad. Very
Yeah.
sad.
Sorry for your loss.
Sorry for your
Uh,
loss.
yeah,
That's
sorry.
terrible.
Thank you. I mean, I miss him every day,
Yeah, and you're being an
and I
advocate to
believe,
educate other.
if I had the biomarkers that I had, I believe my brother could have had them also, you know, and why not test him? They wouldn't even test him.
Yeah,
That's what upsets me.
yeah, and you're raising your voice and making sure that folks are aware of biomarker testing and the importance. Thank you for
Yes,
sharing.
ma'am.
Thank you for sharing. Dr. Burgai, can you talk about side effects that may result from some of
Yeah,
the treatments?
sure. We have to take it by category because the side effect profiles are somewhat different. I think everybody has heard about chemotherapy. Everybody has this vision of what chemotherapy can be.
I don't like
Uh,
it.
yeah, I don't blame you. Nobody
No,
wants to be
I
on
would take a
chemo.
different route. I don't like it. No,
Yeah,
sir.
but chemotherapy is unfortunately a big part of what we do in lung cancer because not everybody has those biomarkers. For example, I think in your case, Pamela, you must have had a very high expression of what we call PD-L1, which is a biomarker for immunotherapy in
Yes, sir,
patients
I
that
did.
have,
It was
yeah, so
90%.
no, so that's
Yes, sir.
great because those tumors respond to immunotherapy without the need for chemotherapy. So it's absolutely appropriate that you just get that. But not
Right.
all of our patients are fortunate enough to have that. In fact, only about 28% of patients would have very high PD-L1. For everybody else with lower level of PD-L1, the standard of care is a combination of chemotherapy with immunotherapy, where the outcomes are still good and we can have
Right.
good responses and durable responses. But obviously, the high biomarker, in this case, PD-L1, is very effective. So what are the side effects of chemotherapy? You know, for one subtype of lung cancer, again, the adenocarcinoma, the more common form, we actually have a form of chemotherapy where most of our patients don't have those traditional things that we associate with chemo. For example, severe nausea, severe vomiting, hair loss, and things like that. So for adenocarcinoma, in fact, there is a chemo where there might be some hair thinning and all of that, but it's very rare to see total hair loss. But these drugs are designed to kill anything that's actively dividing. So cancer cells, by definition, are very actively dividing. So they die faster. But unfortunately, the cells in the GI tract, which is why people get, you know, GI symptoms like nausea and all that, or the cells in the hair they're actively dividing, or the blood cells are constantly dividing. So all of these areas can be impacted by chemo. So lowering of the blood count, if it is a white blood cell count, it could cause infections, or red cells. If it goes down too much, you might need a transfusion. Fatigue is very common. In fact, we think the only thing that can actually help with the treatment-related fatigue is a regular exercise program. It doesn't necessarily have to be in a gym 2 hours a day. Any kind of exercise, walking, keeping yourself active is the best way of combating the fatigue associated with it. And unfortunately, fatigue is common in almost every treatment that we use. Immunotherapy are the drugs that are designed to stimulate your own body's immune system. Once that happens, there's definitely an attack on the tumor, but unfortunately, normal parts of the body, anywhere from your brain all the way down to your toes, can also get this inflammatory side effect from immunotherapy. Fortunately, the percentage of patients who get these adverse events are low, but if you get one of those, obviously you're going to have symptoms. For example, it's common for patients to get inflammation in their colon, causing a pretty bad diarrhea. You can get inflammation in the lung, causing shortness of breath, cough, a condition we call pneumonitis, or inflammation of the lung. So if these things happen, obviously we stop the immunotherapy, and if they are severe enough, we usually cannot go back to it, because if it happens once, there's a much higher likelihood that will happen again. And the treatment is high doses of steroids or other drugs that suppress the immune system. One of the more common side effects of immunotherapy is loss of functioning of the thyroid gland. So the thyroid gland can be monitored through simple blood tests. And unfortunately, in some patients, you know, anywhere from 15, 20%, you know, you have to go on a thyroid supplement because of that. Targeted therapies are a little bit better tolerable, just because, again, they're going after specific mutations. But even there, and even though these are pills, we do get side effects such as rash or diarrhea or skin and nail changes or swelling of the legs. Some drugs in lung cancer can cause the cholesterol to go up. Some drugs in management of metastatic lung cancer can actually lead to depressive syndromes or symptoms in some patients. So there are a variety of side effects that can happen that are very specific to the treatments. So here, I'm not going to go over every single one of them just because of the interest of time, but to give you an idea as to what potential side effects can be associated with each category of treatment.
Thank you. Pamela, would you like to share any your own experience as far as side effects and what resources and supports you use to manage and navigate those
Yes,
side
ma'am.
effects? Sure.
I did the immunotherapy, and I'm just going to tell you, Dr. Borgai, I had dry mouth. That's it.
Good.
I had no side effects at all.
Fantastic.
None. And I'm still, after it's 8 years now, and I'm still booming it up the steps. You know, the doctors are asking me, can you climb steps? Yes, I can. I tell them, you want to race me up them? You know, and they're like, no, we don't want to do that. And I said, well, come on then, let's go. You know, that's just the kind of person, I am. And I'm not giving up. There's too much out there. No way. I got 6 grandbabies and been married 32 years, and I'm, and
Yes.
I do all my normal things every day. You know, I do everything. I'm up and down actually 2 flights of steps every day. So, and I'm not out of breath or nothing like that. So, but all I had with side effects was dry mouth. That was it.
Yeah.
Very, very fortunate, very, very blessed to have that. And that's it.
Mhm,
Mhm.
mhm, mhm,
And actually, when I was having my treatments, because I did it by IV for 30 minutes for 2 years. And actually, I was like coming out of the chair. I was asking him if there was speed in it. I'm just going to say that.
yeah,
And my doctors was saying, no, Miss Dyke, you were speedy anyway, which I am very hyper, I do have anxiety. And it was like the treatment was making me want to come up out of my chair, for the 30
mhm,
minutes. And I felt
yeah,
wonderful. I
yeah.
did. So I
Thank
was
you.
very blessed.
Yeah, thank you. So it's different for everyone, right?
Yes, ma'am.
So, Dr. Vergai, what are some services or other consultations that you recommend your patients to pursue,
Yeah.
and when should those take place?
Excellent question. I'm going to go back to something that Pamela said. I think it's
Hmm.
absolutely essential for you to consider a second opinion. Now, whether you like your first doctor or not, whether you hear what you like or not,
Yes, sir.
a cancer diagnosis is a life-altering diagnosis for many of us. Um,
Yes, sir.
we encourage everybody to go and listen to others, especially if you're interested in clinical trials, because there's so many clinical trials, no one center can have access to all of them. So
Right.
it is a little bit nerve-wracking because it can cause delay in initiation of treatment by the time you arrange for another opinion, gets all your material transferred and all of that. But I think to some extent it might be worth it just to make sure that you've heard at least a couple of different varying opinions here. So that's one thing that I think we just wanted to get out. Other consultations, again, we've talked about radiation. If there is a need, we usually consult the radiation doctors. If there's a need for pulmonary doctors who do just lung care, not lung cancer care, in terms of cough, shortness of breath, and other issues. And sometimes with the development of side effects like that inflammation in the lung, we typically get our pulmonologists involved. I think the one thing that I find very helpful, one is a social service consultation, just to make sure that there is that base of support. And the other is that in centers, usually larger sort of NCI designated cancer centers, I think it's a really good idea to have an appointment with services where there's more of an emotional support. There's more discussion about, if you have pain, how we're going to manage it. These have different names at different centers. We call them palliative services for the most part. But there's research that actually patients who have access to that have much better quality of life. And at least in one study from many years ago, live longer. So I think having those discussions are really, really important. And of course, we hope that all of our patients have access to a really good family support system, so that they can discuss what their wishes are, how they want to be treated, and all of that. I think these are questions that come up one way or another during the first couple of visits with any oncologist taking care of a patient with lung cancer. And I think those are essential, because I think your doctors want to know what exactly your beliefs are and how you would like to proceed. And I think it's important for you to know what your doctor's capabilities are, what the center's capabilities are, and those open communications are actually very, very important. So I encourage everybody to bring those things up when they are meeting with their teams who's taking care of them. And every team, I think, again, you're seeing me as an oncologist, but I would not be able to do what I do for my patients without my nursing staff, without my infusion room staff, without social work, without and numerous many people who touch every patient. So again, going to a center where they have access to all of these support staff, I think is really important.
Thank you. Thank you. And Pamela, who were the people from your experience, your team, your support, that you found very helpful?
It was my oncologist and like Dr. Borgai said, his nurses and, everybody was wonderful with me.
Hmm. Hmm.
That was my support team. But I'm gonna tell you, I don't listen very well. And I am my own advocate. So like he said, Dr. Borgai, I the doctor might tell me something and I say, no, I'm gonna do it this way. I might have a different, route that I'm gonna take. And I'll tell you, I have made the best choices in my battle with this on my own.
Mhm.
Okay,
And my doctor went with me and we did it.
great.
And
Working
guess
with your
what?
team.
He's retiring now, so that's not good. So I
Oh,
don't know what I'm going to do now. It's
Yeah.
hard to find a good doctor. You know, I'm just going to tell you, it really is. Because,
yeah.
you know, I'm not a very, they even put on my chart that I'm an uncooperative patient. So I
You're,
told him, well, you know, at first I didn't like it, but then I said, well, that's all right, go ahead. Because,
you're,
you know, I
you're
want that someone that I can talk to, you know, and relate to. And me and
okay.
my doctor in 8 years did you know, did have that relationship. But now he's retiring. So
So you
I
brought up
don't know
some
what
good
I'm gonna
points.
do.
Well, you brought up some good things that were helpful to you. Being able to have communication, relate, feel like you're being listened and heard. So those are really good points for patients who, when they're looking at their care team as qualities that are important. Thank you for sharing,
Thank you.
Pamela. So, Dr. Borgai, is there anything that, in terms of what people, when it comes to screening and the screening process, what is the screening process for lung cancer?
A very, very important question. So let me just say that now we are pivoting out of necessarily metastatic disease and
Mhm.
concentrating on how to find lung cancer at an earlier stage. Screening is very important to us. And unfortunately, as a country, we're doing a very poor job of screening potential individuals out there who unfortunately could have lung cancer. So screening is designed to find the cancer at its earliest stage where the chance for cure is the highest. With surgery, with chemoimmunotherapy before surgery, and maybe more treatment even after surgery, the cure rates are improving for non-small cell lung cancer. So basically, screening is a method whereby individuals at this point who qualify, and we can go over the criteria, will get a low dose CAT scan. So I have to emphasize low dose because some folks worry about the effects of the radiation from this imaging study. So low dose CAT scan exposes you to as little radiation as possible. These scans are done once a year for at least 3 years in a row. In some cases, might be able to continue. And the studies that have been conducted, supported by our own National Cancer Institute back then, sort of indicated that in individuals who have a heavy smoking history, which was the criteria back then, doing a low dose CT once a year was far better than chest X-ray in detecting lung cancer at an earlier stage. So screening now has sort of become part of what we offer to patients or individuals, I should say, who qualify, who are between the ages of 50 and 80, who have heavy smoking history, who might have quit within a certain period of time, who don't have any other cancers. But what we are seeing is that only about 8 to 10% of patients who we think are eligible are getting low dose CT. And quite frankly, I think we don't understand fully why the country is not getting behind this. It could have to do with the fact that the US has such a large patient population and such a varied healthcare system from one area to another, where it's hard to find an individual who can be responsible for monitoring the CTs, following the patients, because you can imagine if there's something on a CT, you don't want to miss that. You want to make sure the patient knows, you want to make sure the appropriate doctors know. And then I think there are a variety of other reasons why screening has not picked up. We believe in our field that lung cancer screening can be more effective than mammography in detecting, breast cancer. Yet every woman who qualifies for a mammogram has access to one in this country, but not low-dose CT for lung cancer screening. And I think this is where patient advocacy has to be the loudest in terms of getting the news out to everybody and forcing every healthcare system to offer lung cancer screening to everybody, even in remote areas, because it is that effective. Now, it does come like anything else with problems. And problems are patients having unnecessary surgeries or procedures, because what you see on a CT is not always lung cancer. It could be a variety of different things, such as infections, inflammatory things. but we can't know that by just a CT. So if there are abnormalities, then it is possible that it's not cancer, but and that leads to unnecessary surgeries or procedures, and obviously everything can have consequences. But as a general rule, right now, lung cancer screening is what our best chances for detecting cancer early. We and other centers are working on expanding the eligible patient population so that it's no longer dependent on smoking, because there are a variety of other reasons why someone could be at risk of lung cancer. So we are trying to conduct the studies to prove these points and hopefully make lung cancer screening available to more of our population out there.
Thank you. Thank you. And Pamela, as a patient advocate, is there anything you want to add regarding screening?
Not really. I mean, it's very scary to do, but it's anxiety is what it is. But I agree with Dr. Borgai. You know,
Mhm,
there is a lot of people out there that probably does need screened and they're not getting it.
mhm. And you raised a point about fear, and that might
Oh,
be
yes,
the
it's very
source of some
fearful.
fearful.
Yes,
Yeah,
it
yeah.
is.
Thank you. Thank you for sharing that.
Thank you.
Um, so, Dr. Bogai, what does quality of life, long-term care look like for patients in this population?
I think that is probably one of the most important questions that needs to be discussed at the time of diagnosis and before we start the treatment. Um, Quality of life is awfully important. Everybody has a different take on what quality of life is and what they imagine their life should be or would be on various treatments. We have made enough improvements that I think, compared to about 20 years ago when I first started doing some of this, I believe the quality of life of our patients are far better. I have patients who can hold on to full-time jobs. Yes, they have to come to the clinic every 3 weeks, get treated, so they can't be at work for that day, or they have to show up for CAT scans and blood tests, but they feel well enough that some of them hold on to jobs for a very long time. And these are sometimes very active jobs. I have patients who take care of grandkids and are on treatment, yet they feel well enough that they can do that. And unfortunately, I do have patients who just suffer from these side effects to the extent that we sometimes have to hold treatment or stop treatment because the quality of life is so compromised that it becomes meaningless. Um, Treating a disease like metastatic lung cancer, which again, unfortunately, can be incurable in some cases, becomes difficult when some patient or some of our patients cannot enjoy life. They cannot be their family members. They cannot get out of the house, or worse, they're in and out of hospital with a variety of side effects. So the reason you want to be able to have that open communication with your doctor and your team is exactly these. As a doctor, it's very difficult to walk in and say, I'm not going to treat you. But if I've had that discussion with my patients, if I know that my patient wants to have a really good quality of life, it's a little bit easier for me to open that discussion when something wrong happens in terms of the treatment. And again, these are really powerful drugs. They're designed to be powerful. We're fighting against cancer. And therefore, sometimes these side effects can be severe. And again, knowing when to change treatment or hold treatment or adjust the dosages of the treatment is very important, and most oncologists are trained to do that. But B, for our patients to tell us, look, this is not the way I want my life to be. Let's change treatment or come up with a different strategy. And I think you should feel comfortable enough to tell that to your doctor. Is really important for all of us. So I would say that's probably one of the more important aspects of your care that you should openly discuss with your family and with your treating physicians, just so that everybody knows that we are on the same page.
Hmm. Hmm. Thank you. Pamela, can you tell us a little bit about your experience with follow-up care since you've completed your main treatment?
What do you mean follow-up care?
Follow-up care, what's been your experience in terms of the care that also helps you with your quality of life and helps with,
I've just been getting scanned, you know,
yeah.
every
Mhm.
year. And I'll
Okay,
tell you, Dr. Borgai, I'll tell you, I did go do a second opinion at a
Good,
big facility.
good.
And guess what they told me? That I had 6 months to live.
Oh, I
So
don't
you
believe.
know what? I
Oh
told
my.
him I fired 2 doctors at that hospital because they cannot tell me
No,
how I feel. And then I don't believe they should be able to tell any patient that they have 6 months to live. When I left that hospital, you can just imagine what was going through my head.
I'm
mm,
And
so
I do
sorry you had to
not
go there.
agree. I do
I'm,
not
yeah,
agree with any
yeah.
doctor that says that to anybody.
I agree
yeah.
with you, Pamela. I hate that statement. When I hear that, when my patients come and say the other doctor said that, it just gives me, it's, I don't understand why people talk like that, but unfortunately, sometimes that's what it is. Now, I think we have to be honest with each other, but to come up with a specific time like that to me, is pushing it a little bit. Anyway, I have
Yeah.
Mhm.
some views
Well,
on
I
that.
think, yeah, I think what I'm hearing though, for what you were sharing, Dr. Burgai, and also Pam, what really works is communication and being
Exactly. That's
able
it.
to talk to your healthcare team. And what Dr. Burgai was saying, how it really helps with quality of life. So thank you, for sharing that experience and
Well,
your.
actually, can I say something? Actually, I had 2 doctors at the big hospital that I went to.
Okay.
Mhm.
And one said I had 6 months. So I told him I walked out of his office. Then the second one told me that I had 2 years if I was hit aggressively with chemo and radiation. That wasn't
Mm,
my road to take. So I left. And then I came, we did the biomarkers and all that, and I got on the right treatment. And I had to
mhm,
push for that treatment.
Good. Yeah.
mhm.
That's why
So,
I'm my own advocate. I advocate for myself and I will continue to do that.
mhm, thank you. And just as we're gonna get ready to go into a little bit of Q&A, I wanted to also, as we were sharing a little bit about some of the services that are important around quality of life. Earlier, you mentioned palliative care. Are there any other supports that would help with, and we talked about communication with their healthcare provider being key.
All right. So again, I think in the last several years, we have seen a flourishing of multiple patient support groups that are national and some of them international organizations. They are available, through a simple search. For example, for patients with an EGFR mutation, we have specific support group. For patients with an ALK alteration, these are all biomarkers. We have a specific group. Many of the cancer centers actually have patient support groups where you can be put in touch with someone with a similar diagnosis who's gone through what you were going through to have a better idea as to what your life can be like. So we really encourage those activities and participation in the patient support groups. They can also disseminate research and news that comes up so that you're aware of what is happening with your particular lung cancer. For example, if a new drug becomes available, these patient support groups are really good about amplifying that news and making sure that all their members and all the patients who are there and their family members are aware that there's a new drug or a new test or a new technology that has become available. So I think those are valuable to many of our patients, and the information is usually very validated, and it's research, and it's very sort of supported by data. So I think the patient support groups, it's one thing to hear it from me that, hey, you're going to do okay, you're not going to have a lot of side effects. It's quite another thing to hear from a patient who, like 3 months ago, was my patient and went through the same thing, and you can compare notes and, did you have this, did you have that, and what exactly happened. So talking to somebody who's experienced that, kind of like what we're hearing from Pamela, I think can be very important in sort of having an idea of what life is going to be like when you want to embark on a new treatment.
Thank you. Thank you. So before we move into our Q&A, and for our audience, if you have questions, this is a good time to post your questions. You both have an opportunity. If there's any last minute thought, something important that you want to share that we didn't touch on, please do so.
Well, I do want to tell Dr. Borgai that I do have a support group that I opened.
Yeah.
And I was on another support group that I went on myself. And, I believe in God. And I was putting things on the group, about God, because I believe in the power of prayer. I believe in God. And I was kicked off the group. So, you know what? After my third time being kicked off, I said, I'm going to open my own group, and I'm doing quite well. I have 654 people on there, and they're wonderful. They're
Good for you.
wonderful.
Yeah.
Thank you.
And
Most of these,
we do talk back and forth, about everything.
Yeah.
If anybody needs any guidance, or if I need guidance from them, they might be able to help me too,
Yeah.
Thank you.
I would just say that as difficult as it is to get a diagnosis like any kind of cancer, particularly lung cancer, and it really truly is difficult. There are a lot of good things out there. There is a lot of hope. There's a
Yes,
lot of
there is.
research. Newer drugs are coming. And I think having a wide enough network where you can be aware of the research and development and going to different places to get these opinions is important for our patients to sort of know that, yes, as difficult as this diagnosis is, there is hope. No one can make promises. I will never look you in the eye and tell you that, I can cure this, or I can do this, or I can do that. And I also promise you, I will never come and say you have this much to live. I think what
Right.
I can
Yeah, I
tell
don't
you
agree with
is
that.
honestly where we are and openly talk about what treatment can or cannot do and have that kind of a relationship with the patients. But I really truly believe that, we're on the brink of making major discoveries again, kind of like what immunotherapy and targeted therapies were about 10 years ago. And some of the protocols, some of the trials that are ongoing have the potential of changing the face of treatment the way we know it. So keep at it.
Perfect.
Don't give up hope. And hopefully we all get
I'm never giving
better.
up. Never.
Yeah.
Great, thank you. We do have a couple of questions, so I want to make sure we get to. So, first question is, can you speak to immunotherapy, successive treatment, side effects? What about diet? What can a patient do for best possible outcome?
So
Well,
I think how Pamela has gone through immunotherapy. So I don't know, Pamela, if you want to make a quick comment about the side effects, and you said you did very well with
I
it.
didn't have any side effects, Dr.
Yeah,
Borgai. All I had was dry mouth. But I'll
yeah,
tell you what I did. I did a lot of protein with eggs. I did a lot of eggs, in the mornings. I did a lot of protein and, and a lot of vitamin C, 1,000 milligrams. That was my day. That's my daily ritual, to do that. And so I did protein's very important, you know, and I think that helped with my, with everything.
yeah.
Great.
So I would say that the side effects are real. Again, as I said in the beginning, it doesn't happen in everybody who gets exposed to immunotherapy, but
Right.
there's a potential for it to happen. These
Right.
are,
I
again,
have people in my group that
yeah,
has a lot of side effects. Yeah.
yeah. And again, it's we're not able to predict who is going to have a side effect and which kind, and who is not going to have the side effect. We haven't gotten there. Again, there is research to try to identify that, but the side effects can be these inflammatory reactions, such as inflammation around the brain, inflammation around the heart muscle, inflammation in the kidney, liver, in the lung, in the colon, and depending on the site, you could have various symptoms affected because of the organ. The more common ones are fatigue, rash, thyroid dysfunction, for which you might have to take a thyroid pill for the rest of your life. diet is an interesting question. We don't have clear evidence what kind of diet is good, what kind of diet is not good. There is evidence that the gut bacteria can have an impact on it. And what I mean by that is that, as you know, we have bacteria in our gut, hundreds of millions of these. And there's some intriguing research that actually says that the changes in the gut can have an impact on response to treatment. This is still very investigational. We don't have all of the information yet. It is an area where there's a lot of research. So the way I interpret that is that having a nice, varied, balanced diet becomes really important. You should have protein, you should have calories, you should have minerals, you should have fruits and vegetables, kind of like what every doctor would recommend to their patients in terms of a balanced diet. So I don't have a concrete answer for you as to whether, if you have more of one thing versus the other is going to be good. But there is, again, as I said, investigations in progress for that. And as far as what a patient can do with the best possible outcome, open communication. If you think you're having a side effect, immediately contact your doctor so that it doesn't become a lot worse. Keeping yourself active, regular exercise program, nice balanced diet, hydration. I think those are the important aspects of any treatment, particularly for lung cancer.
Thank you.
Yes, sir.
Just a follow-up, that was, can you speak of risk to avoid with lung cancer with autoimmune disease? I hope I read the question right. Can you speak of the risk to avoid with lung cancer? Yes, with autoimmune disease.
The risk to avoid, so my interpretation is if somebody has an autoimmune disease, can we use certain drugs? So when the immunotherapy drugs were approved or were undergoing clinical trials, and this is one of the issues with clinical trials, patients who had any kind of autoimmune diseases were excluded out of concern that we could worsen those side effects. So there's little information, although we're beginning to have more about what to do if somebody has a significant autoimmune disease. Now, some autoimmune diseases aren't necessarily affected with chemotherapy or targeted therapy, but some autoimmune diseases, if exposed to immunotherapy, can actually become worse. So it's sort of a case-by-case basis. And if somebody is on, very active treatment, for example, for colitis, which is something that happens, inflammation in the colon or Crohn's disease, then that individual might actually suffer worse side effects with immunotherapy in terms of really bad inflammation in the colon. So in conjunction with physicians who are managing the autoimmune disorders, selectively, we sometimes do offer immunotherapies to our patients, but that again is on a case-by-case basis and requires a very much a team approach. So whoever is managing the autoimmune diseases, whether it's a GI, a pulmonologist, a rheumatologist, and the cancer physician, have to be in touch with each other to try to come up with the best treatment strategy.
Okay, thank you, thank you. I think we've gotten all the questions answered for tonight's, and we do have a poll that is popping up on your screen, asking you to please take a few minutes before logging off the webinar to complete the poll. So I want to thank our speakers, Dr. Bogai and Pamela, for joining us today for this webinar. Thank you to our sponsorship, our sponsor, Novacure, for their generous support of this event, and to our program partner, Lung Cancer Research Foundation, for their collaboration and support. This event has been recorded and will be made available on Cancer Support Community's webpage that is posted in the chat. Thank you again for your attention, and we look forward to seeing you at our next webinar. You were amazing panelists. Thank you so much, Pamela.
Thank
and thank
you.
you,
Thank you
Dr.
for having
Bogai.
me.
And I wish everyone a good evening.
Thank
You
you.
too. Thank you very much.